Before I start, I would like to tell you that I do not have anything to disclose. And I would like to thank the Urodynamics committee for giving us this opportunity. And also I would like to thank my co-authors, Dr. Oktay Demirkesen, Dr. Mauricio Plata, and Dr. David Castro Diaz for their collaboration and support. So the title of our teaching module is Detusor Leak Point Pressures in Patients with Relevant Neurological Abnormalities. The basis of our information regarding detusor leak point pressure is originating from McGuire's studies from 1981. These were retrospective observations, video urodynamic studies of children with myelomeningocele and urinary incontinence secondary to impaired bladder compliance. The basic purpose of these observations was to define a certain cutoff value of detusor leak point pressure where we can predict the upper urinary tract deterioration. However, this concept was further applied to different etiologies of neurogenic lower urinary tract dysfunction, also in adult patients. The ICS today defines the detusor leak point pressure as follows. The lowest detusor pressure at which urine leakage occurs in the absence of either a detusor contraction or increased abdominal pressure, according to the last terminology report published in 2002. However, today we see several controversies regarding the measurement and clinical interpretation of detusor leak point pressures. For example, the cutoff value of detusor leak point pressure to predict the upper urinary tract damage is debatable. And measuring the LPP lacks standardization today and carries certain pitfalls. And today we see that in many studies, the LPP in neurogenic lower urinary tract dysfunction has been misused as detusor contractions instead of reduced bladder compliance. So this ICS urodynamic teaching module consists of a webcast presentation in combination with the manuscript and a standard education of good urodynamic practice for everyone who is caring for patients with neurogenic lower urinary tract dysfunction. My presentation will focus basically on testing requirements, clinical workup and analysis. The manuscript additionally focuses on scientific background and review of the present literature. And one of our aims in this presentation is to standardize and improve the method of the LPP measurement in patients with neurogenic lower urinary tract dysfunction to minimize performer and patient-dependent variations. We have taken the two very important reports into the consideration when we have worked on this module. The first one is the ICS report on good urodynamic practices, and the second one is the International Children's Continence Society's report on the standardization of the terminology of lower urinary tract dysfunction. The standard urodynamic equipment has been found in our review as an appropriate one, and I'm not going to talk about the details of it because this has been very well described in other reports and also in previous teaching modules. The patient's investigation should start in spine position with an empty bladder. We have also to say that ICS recommends sitting position in suitable patients, and this is recommended with a degree of B. However, there is no evidence for the influence of specific positioning of patients with neurogenic lower urinary tract dysfunction on the detusor leak point pressure. We know that using progressively larger catheters increase the measurement of the LPP. So small size catheters are always preferred. The rule should be as thin as possible, and one catheter systems supported with the level of evidence of 4. Today, most of the studies are being performed with 5 to 8 French double-lumen cystometry catheters with water cystometry. We also have seen that underestimation of the LPP is possible when suprapubical catheter is used. There is no standardization about the filling rate in the ICS Good Urodynamic Practice report. It is usually done with a rate dependent on age in children that may be calculated by different methods. And detusor adaptation to volume may be challenged in high filling rates. Therefore, our committee prefers the slow medium filling rate in these studies. Although ICS has classified, ICS doesn't use this classification anymore, as you know. The ICS classifies the filling rates as physiologic and non-physiologic today after the last report. In order to calculate the optimal infusion rate, day-to-day bladder capacity may be calculated using voiding diaries or catheterization diary volumes. 5 to 10% of known predicted capacity may be used in children. And especially our committee thinks that slow filling rate in adult neurogenic patients with a non-hypocompliant bladder is important, supported by the expert opinion. Infusion pump devices, rather than gravity-type infusion systems, are advocated to avoid iatrogenic bladder pressure increases. The influence of fluid temperature on detusor leak point pressure has never been studied. More accurate representation of bladder activity with natural fill, that is maybe the ambulatory one, natural fill cystometry in children may be achieved. Another problem exists about the detection of the urinary leakage. One way of doing that may be one person observing for leakage and another observing the recording and marking pressures. There may be a more accurate fluoroscopic visualization of the contrast around the catheter in video urodynamic studies. Another question that we have tried to answer was how and when to stop the cystometry. There was no strong data in the literature to answer this question. It is our belief that cystometry may be stopped when the detusor pressure exceeds 40 centimeters of water to prevent complications and to protect the upper urinary tract. Or a maximum bladder volume at intermittent catheterization is reached can be another stop point. Or some authors have stopped the cystometry during their studies when a strong neurogenic detusor overactivity contraction has occurred. Not all cystometry in this patient group ends with leakage. Sometimes, or in many cases, cystometry is ended without leakage, and the authors of this teaching module have decided to mark this point as end filling pressure, as it was shown in many studies. There is a neurogenic detusor overactivity leak point pressure which has not been defined yet. This is something that we propose as a new terminology. If leakage occurs with an episode of neurogenic detusor overactivity anytime during filling cystometry. In non-neurogenic patients, it has been previously defined as detusor overactivity leak point pressure. Although the aim of this presentation is not to talk about basic pathophysiology, I would like to show some data about it. The LPP is the pressure which overwhelms the bladder outlet resistance and causes urinary leakage. It reflects the resistance of the bladder outlet or the external sphincter. And the basic ideology that high diastolic leak point pressure puts the upper urinary tract into risk is a valid one. However, there is no certain cutoff value that we can rely 100% on it. The accepted cutoff values that we use today, especially the McGuire's 40 centimeters of water, doesn't have a high level of evidence. In our treatment policies, reduction of outlet resistance for improving safe bladder storage and preserving upper tract is targeted. For this, finding an absolute value of the LPP is very important of us. However, is it really possible? There are not many studies that have investigated the cutoff values of the LPPs. One study has shown that there was no upper urinary tract deterioration of many patients with the LPPs of 40 centimeters of water in the long-term follow-up. Another study in children has shown that 20 centimeters of water as the cutoff value for the LPP was better than 40 centimeters to predict the risk of upper urinary tract deterioration, as you see on the table. There are so many answers that we have to answer regarding the clinical implications and basic pathophysiology. One is, what is the clinical significance of the overactive leak point pressure versus the conventional DLPP in neurogenic lower urinary tract dysfunction with low compliance? There was a study which showed that significant association with hydronephrosis in patients occurs when the neurogenic tensor overactivity exceeds 75 millimeters of water. Of course, the total duration of the tensor overactivity contractions are also very important. In this study, the only statistical significant urodynamic variable for upper tract dilatation and vesicular reflux has been found, the duration of the tensor overactivity contractions. However, the level of evidence in both of these studies was not high. The treatment of patients with a high DLPP is indicated to reduce the number and amplitude of overactive tensor contractions and targets improving the bladder compliance. Another target may be to expose the urinary tract for a shorter period of time to high pressure in between bladder emptying periods, with or without CIC. Therefore, it is very important to know in these patients the CIC schedule. As I said, significant numbers of patients with neurogenic lower urinary tract dysfunction do not leak during the study, where the end-filling pressure should be noted. This has been shown in one study with an increased bladder wall thickness and increased urinary levels of TGF-beta1, NGF, and TIMP. These biomarkers have been very promising in the future to replace maybe some of the urodynamic parameters that we use today. So, DLPP, a part of systematic evaluation of children and adults with neurogenic lower urinary tract dysfunction to help predicting or preventing upper urinary tract dysfunction, has been recommended with a grade of B or C as the result of our teaching module. Recommendations of ICS and ICCS should be followed today for systematic equipment and for the measurement technique. Discrimination of high-risk patients on the basis of the LPP has been recommended again with the grade of B or C. However, we have to note that the LPP should not be used as the sole parameter to decide on invasive therapies in this patient group, such as bladder augmentation or sphincterotomy. Other factors that predict upper urinary tract dysfunction should be combined, such as bladder compliance, volume where leakage occurs, duration and amplitude of tensor contractions, and volume that is obtained by CIC. It should be known that there is a low sensitivity of traditional cutoff for the LPP that was 40 centimeters of water for the prediction of upper urinary tract dysfunction in this patient group. Future research to standardize the technique and better classify the LPP cutoffs is certainly needed. The predictive value of the LPP may further differ depending on the different underlying pathologies, such as myelomeningocele, multiple sclerosis, or spinal cord injury patients. So therefore, these patients group should be evaluated separately, and they should not be put into the same basket. I would like to show you finally an example of the urodynamic study and again make it more clear what the difference is between the DLPP and neurogenic torture or activity associated DLPP. Here, this is the DLPP according to the definition of ICS, where there is no increase in the vesicle and the abdominal pressure. Where here, however, there is a neurogenic texture overactivity, and when the leakage occurs, unfortunately, in many examples, that has been today reported as the LPP, however, it is not. So we have to differentiate at least between these two phenomena. End filling pressure should be taken into consideration if the leakage does not occur during cystometry. However, the clinical relevance of EFP is not clear. I would like to thank you for your patience.
Okay, thank you for your presentation, Professor Tarkan. So, neurogenic detrusor leak point pressure, or detrusor leak point pressure in neurogenic patients. We can have a short discussion. If somebody wants to ask a specific question, you are welcome. Otherwise, I'm going to ask you a question. So take care. Okay, the question for you is, who is doing urodynamics for neurogenic patients? You are. You are. Are you using the detrusor leak point pressure? So, is this helpful for you to teach what is the knowledge? And is there anything that you miss in this presentation? That you tell me that you do things different? So you have another strategy. Go to the mic, please. You do have a question. Can you use the mic? Yep.
Thank you for the lecture. When you are doing the study and the bladder starts firing and the patient starts leaking, and he leaks to the point that he empties his bladder. Okay, and then this event starts happening again and again. When do you start? Do you decide to stop? And this is which one of them you pick as the?
Okay, we are talking about neurogenic patients. Is that right? Okay. So
can you stay at the microphone? At the microphone for a moment.
Okay. This is again, I can answer this only at a very low level of evidence, because if you look to the literature, there is no answer to your question. However, in this patients, what we are doing is, in my own clinical practice, we repeat it 2 or 3 times. If we see that we have the same result after all these repeat cystometries, and we stop it. You have to stop it after leakage occurs. You should not continue your cystometric filling, and empty it and then start again.
I have a question for you. What do you do?
I do it like 2 or 3 times just to make sure that it's really happening.
Yep.
And then I stop.
So, and what do you decide about the leak point at that moment?
The minimum, the least pressure, the minimum.
Yep. Good. So that's what you do as well.
Yeah. I think.
Should we have something like that into the slides? Or?
Yeah, maybe. Yeah. We can add this. Yeah.
So thanks a lot for your comments. You have another comment?
Yes, please.
Good. Well, you're welcome.
It's an observation I've noticed once. I don't know if this is related to the subject. I was doing a study one time, and I was doing it in the spine position. She's a neurogenic lady, and the curve was going very smooth and no problem. And then I put her in sitting position and she started firing. Does the position differ?
This was covered in the manuscript as well as in the presentation. There is no data about it.
No.
I can show you, but if you remember the slides, the ICS requires the sitting position whenever it is possible. However, the effect of position on the LPP measurement has not been studied yet. There's actually so little that has been studied about the LPP since 1980s, and we have taken all these cutoff values as unchangeable rules to our clinical practice. However, it lacks really a good level of evidence. But now the two new emerging studies have shown that this cut-off level is not true. And in the manuscript, I think we will have the opportunity more focus on the basic pathophysiology. And the upper urinary tract deterioration is not only depending on the LPP, of course, to other factors, the duration of the pressure that the bladder is exposed to, the amplitude, and so many other things, of course. And again, the etiology is also very important, the etiology.
So you may be right about the position, and there are definitely individual variations and effects on while repositioned. However, there's no good evidence, so we cannot put that in an evidence-based educational module, and that's a bit of our problem. The lack of evidence is more stringent problem than the practice. And we start off with this practice. And I think if everybody follows the practice, we will see the evidence for what happens, and then we can collect the evidence and write a new practice. I think this is the way to go forward. And maybe we will have new evidence in 5 years, and then you have to rewrite and represent.
Yeah.
Okay, that's the deal. There's the other thing, that is the filling rate. You mentioned some things about filling rate. How do you all decide on filling rate in the neurogenic patient? Who decides on filling rate on the basis of something like avoiding diarrhea or catheter volumes that are known to you? Nobody of you. So you just push one filling rate for every patient. So that might be good practice, but there's no evidence. That's my answer, and that's in the module as well. So
we do a standard filling rate and then adapt it for what we actually see and repeat the
Okay.
studies.
Okay, that's a way to do it. So you start with the standing filling. That was the comment. Start with the standard, and if something happens, adapt it. But I basically do not know what's going to happen, what you make adapting, and then
Compliance changes, we'll start the study over, we'll adjust the filling rate, see if
Yeah.
the same compliance issue.
so, and then you slow down the filling rate. So we have a discussion now, so adapt it while doing it, and then you slow down the filling rate, and you will end up with a slightly bigger capacity, is it?
Mm-hmm.
But does it change management in that case? I doubt. There's not much evidence, so I can say yes and you can say no, and the other way around. We have no evidence for that, so we have to collect evidence. What's the filling rate influencing what we are seeing?
Exactly. This is very well actually included in the manuscript as well, this point. Yeah.
So that's the other thing. And who does video? That's my last question. I'm not going to bother you. So you do video. What is more important, that you see the leakage outside or around the catheter in the video? You look for leakage around the catheter, and that's 1 second before leakage into the funnel of the flow meter or seeing leakage. And does that change, that 1 second, your diagnosis? Is it worthwhile, the video? Yeah. So you need radiation exposure for that. There's a little bit of evidence in the literature.
Yeah, my personal opinion is that video is not very much needed in the measurement of DLPP. Of course, again, I mean, there's no strong level of evidence to support this. I think video aerodynamic studies are especially important in children with myelodysplasia when we also consider the reflux into the concentration. I think this is the most important point of aerodynamic studies.
Anything to be said about the trusal liquid pressures in neurogenic patients? You can now stand up or be silent for the next 5 years. Now is the chance to change practice in the world. Okay, use the mic. Use the mic, please. Yeah. The effect of the? Have you mentioned that in the?
I did.
The temperature, and there's no evidence.
Yes, actually, yes. I may be confused between the manuscript and here, but we have mentioned it.
Who uses another temperature for neurogenic patients than patients without neurogenics? Who does use warm water? You use warm contrast. Yeah. So. Okay, there's another comment.
It's the same comment, but I think that urodynamics are going through a good urodynamic practice from the ICS, so there is no change in temperature of good urodynamic practice size.
Okay, comment. There's no evidence that temperature is relevant. That we agree with that. Mm-hmm. Yeah. Okay.
Peter, just maybe one last comment. My co-authors are not here because they are speaking in some other talks. So the authors they wanted actually me to strongly mention that the clean intermittent catheterization volumes are very important in the interpretation of urodynamic studies. In this patient group especially, if you just focus on the urodynamic results, we will fail. Okay, especially to protect the upper urinary tract. We have to put the CIC schedule in front of us and see the volumes, how the kid or the patient is doing, and then we can predict maybe how much the bladder and the urinary tract is exposed to pressure, just looking at the volumes. I think this is a very important point.
Couldn't agree more, and by the lack of evidence, I think this is nevertheless the new standard, that we take in account that whatever we know from the patient to start off doing the urodynamics, and that at best, at least is avoiding diary or volume diary based on catheter volume or voided volume or whatever. Yeah, thanks a lot.
Thank you.
Okay.